Geraldine will come to you in 1 second just to let colleagues know who is sitting here in Skipton House. My name is Richard Taunt. I'm working with Public Health England on this important work, and I'm going to be chairing today.
Hi everyone, it's Maeve Hartwell here, one of the public mental health managers here at Public Health England, leading on this work with Lily Makura and Adam Oyekam.
And I'm Lily Makura, Deputy National Lead for Public Mental Health here at Public Health England.
Hi, I'm Adam Oyekam, and I'm supporting Lily and Maeve in this important work.
And Geraldine, thank you very much for raising your hand. We're going to unmute you. Geraldine, good morning. Hello. Geraldine, I think you raise your hand. If you want to put in a question, please do. Otherwise, we'll continue on. Okay, thank you very much. We'll so if people do want to join in the conversation, just raise your hand and we'll bring you in verbally. So hopefully that's clear in terms of how we're going to run the webinar this morning, that we are going to be taking comments sort of verbally by using the question function, but please again do use email if there's other issues which you want to raise. I hope that's all clear for everyone. I think without further ado, we're going to run through the slides. These are the same slides which came round to you yesterday. And they're also available in the handout bit for you if you want to have another copy. But I'm going to pass over to Maeve to talk us through the work.
Thank you, Richard. So you'll be able to see on our first slide, the aim of our work is to galvanise action. The Prevention Concordat programme for better mental health aims to galvanise both local and national action around the prevention of mental illness and mental health problems. We're aiming to do this by facilitating every local area to put in place effective prevention planning arrangements led by health and wellbeing boards, clinical commissioning groups and local authorities by the end of 2017. And to do this, we're going to try and enable every area to use the best data available to plan, and we're going to support the commissioning of the right mix of provision to meet local needs. And just to be clear, the work covers prevention in the widest sense, from the promotion of good mental health through to living well with mental health problems and everything in between. And it's part of our stakeholder engagement process to discuss the scope, which is part of what we're hoping to discuss with you today. But our starting point is that we are talking about prevention in the widest sense. So where did this work come from? Over the course of last year, both Future in Mind and the 5-year forward view for mental health highlighted a strong cross-society consensus on the need for change and for the need to move upstream. They both highlighted the need to focus on effective interventions at scale, working alongside communities for greater impact. The 5-year forward view also talked, of course, importantly about the need for a boost in early intervention, but that it must be accompanied by a similar focus for mental health promotion, prevention and improvement. And there at the bottom of the slide is the actual wording of the recommendation which we've been using to develop this program of work. As I mentioned previously, our approach is deliberately broad and is informed by the WHO approach to public mental health. And the remit of our team in Public Health England, which is again informing this work, is that everyone, irrespective of where they live, has the opportunity to achieve good mental health and well-being, especially communities facing the greatest barriers and those people who have to overcome the most disadvantages. This includes people living with and recovering from mental illness. And our aim is to have a programme in place to support local action by the summer 2017. And our focus is on putting in place effective prevention planning arrangements. So we're not talking about individual prevention plans, we're talking about having effective planning arrangements, because we understand that this is going to be across a whole series of plans and a whole series of strategies and actions happening at the local area. So how are we going to support this local action? In the first year of the Prevention Concordat programme, we're aiming to create a suite of resources to help support local areas. The first of these resources was commissioned last year and published in July, and the Mental Health Foundation led that work, and it was a rapid review of the evidence of what works, called the Mental Health and Prevention, Taking Local Action for Better Mental Health. The rest of the products are coming in early 2017. The first of these is the Mental Health Joint Strategic Needs Assessment Toolkit, and this is where we're talking about trying to support every area to use the best available data, and that's what the focus of the toolkit will be in terms of helping areas to develop joint strategic needs assessments specifically on mental health. The second product is an update on the return on investment publication that LSE published in 2011. So it looks at some specific interventions on mental health promotion and prevention, and alongside that, as well as providing a report, also provides an interactive tool which will help local areas to understand what types of return on investment they would get if they invested in these specific interventions. And that's due for publication, we're hoping in February, but the final date has yet to be finalised. And then the third element of the work, sorry, the fourth element that we're working on collectively here as a team with Richard is the development of the local prevention planning guidance. And the idea here is that this guide speaks to health and wellbeing boards, local authorities and clinical commissioning groups, and draws together everything we hear through our stakeholder engagement events and the products leading up to the development of this, and pulls it all together in a guide and a resource for local areas to understand what do we need to do to put in place effective prevention planning arrangements. And the final element of the work in its first year is training for the existing elected members, mental health champions, to support them in their development as prevention-focused leaders. And the pilot is going to be running this year in March, and will hopefully be developed and rolled out throughout that programme over the course of next year. So as I've mentioned, all of this work is going to be informed by stakeholder engagement, so we're delighted to have you with us today to focus our discussion. We're hosting this webinar plus 2 others next week, and then we go into a series of face-to-face engagement events up and down the country. The first event is in Birmingham on the 30th of November, then we have an event in York in early December, one in Bristol, and then in London. And we would be absolutely delighted if you or your colleagues would like to join us at those events as well. Alongside this work, the King's Fund are also undertaking a stock take of existing good practice across England. So they have 2 elements to this work. The first is a random sample of looking at existing plans in randomly selected areas across the country, as well as a selected sample where we understand through our centre lead networks there is good practice, and if you have any more areas that you'd like to highlight to be included in that work, do please let us know. And this will help us to understand, what is already happening, what exists, what is out there, and that will help us to inform what we write in the guidance in terms of understanding where we're starting from. And so that's all happening leading us to the end of this year, and as I said, we're leading up towards finalising the set of guidance in February. And as we've got on the slide here, places are still remaining at these events, so do please sign up if you'd like to join us.
May, thank you very much indeed. I think we're going to pause just for a second. We've got some really meaty questions to discuss, but we're just going to have a brief pause for any short questions of clarification on the programme. And again, you can do this in 2 ways. You can either raise your hand and we'll bring you in verbally, or you can also use the text function to send us questions through that. And just whilst I give people a second to think, if you do want to come in, maybe we've had a great question come through from Kate using the function, saying, why don't we call it a promotion and prevention Concordat to better reflect the breadth we described?
Well, I think that's really helpful feedback, Kate. I think what we're saying at this stage is we've used the language that was given to us in the 5-year forward view at this stage in order to just explain what this work is and where it's come from. But the point of this stakeholder engagement is to get this kind of feedback. So the final language that we use to describe the work is not finalised yet. So it's really helpful to get that perspective in and to understand that. And we do understand that both the word Concordat can be challenging because it doesn't necessarily speak to the public directly, and it also brings an understanding and brings to mind the crisis care Concordat. So we are very alive to the issues of the final language that we use. So thank you for your useful feedback.
And maybe I suppose I get to play a bit of devil's advocate here. So what you're saying is the language here is up for grabs. We're keen for views on it.
Yes.
Fantastic. And so if others have any short questions of clarification, please type it in the questions function. Or if you would like to come in verbally, do raise your hand. And we'll bring you in. We'll give people just a second to think about if they would like to do so, and then we'll move on to our main questions of discussion for this morning. Can I just say we have over 20 colleagues on the line, so it's from all parts of the country, so we are incredibly grateful for people giving up their time this morning to join us. You are very welcome. I think so. This is not your last opportunity to ask questions by any means. So we are going to move on to the main discussion questions. But if people do want to continue to bring in to ask questions more about the nature of the program, please continue to do so. The text function is a really good way of doing so if you want to use that. Maybe we have 3 areas of focus for this morning's session. What are we talking about?
So this morning we wanted to get your views on 3 areas, as we outlined, on interventions, on the process that people will need to go through at a local level, and how best to make the case. So we'd be really interested in your views on understanding in your area what specific areas or interventions to improve public mental health are being prioritised. We'd also love to know in your area what was the process which determined which areas to prioritise. And is there a shared public mental health strategy for your area? And finally, in your area, how has the case been made for public mental health? Did the statutory responsibilities of local authorities and clinical commissioning groups play a role? And I'll just reflect a little bit more on that final question. Through our engagement to date, including particularly with the elected member mental health champions, they've been very clear about the tightening public sector finances facing all local authorities, and their view that unless something is a statutory responsibility, it's incredibly difficult to make the case for it currently in the current environment. So we're interested to understand what can we do on the prevention agenda that is tightly aligned to the existing statutory responsibilities of local authorities and clinical commissioning groups. So I hope that question makes sense. So that's a run through of the 3 areas for discussion, and I'll hand it back to Richard.
May, thank you very much. If you're looking at these questions thinking, wow, this is broad, yes it is. And we'd really welcome your views across these areas. Part of the hallmark of this whole agenda, as I'm sure colleagues are well aware, is the breadth of topic matter we're covering. And so we are very much looking for broad views at this point. So just to remind colleagues, 2 ways to come in. Either put your questions in on the text or raise your hand so that we can bring you in verbally. So what we're going to do is we'll take sort of 3 or 4 interventions, sort of questions, comments, clarifications at once, and then I think Maeve and Lily will discuss, and then we will then we'll sort of respond, and then we'll come back to questions. So I think first person to have raise their hand is Bruce. So give me a second, Bruce, and we're going to unmute you. 1 moment. This feels like a radio.
Can you hear me?
Bruce, can you hear us? You're unmuted if you'd like to
I can hear you. Can you hear me?
Oh, we can, yes. Now it does sound like a radio phone in. Bruce, please.
Yeah, I guess I have a particular issue whenever I'm asked about public mental health, is that it's not meant to sound glib, but really that all health and all illness is physical and mental, and so everything that we do has an impact on mental health. Everything that the council does, and if it didn't, I don't know why we'd be doing it. And I just came up with a list of about 14 areas that are very closely related to mental health to me, that even seem to be the ones that are more correlated. But I think it's quite difficult to explain what you mean about mental health compared to what you mean about public health generally. And it's not at all an obvious question. And I don't know if it'd be helpful just to run through the list of the areas that I consider to be areas of focus on public mental health. It's a long list, but I can give it to you if you want.
Bruce, please do.
Well, I mean, we start with our
2 minutes. You're great.
We start with our work in schools, and of course education itself, and then the anti-bullying, and then around that health visiting, school nursing, a particular survey we do about attitudes, then all our early intervention work with children and families. We have a wellbeing college that brings together all the local information about social prescribing, volunteering, counselling, outdoor activity promotion. We have a whole strategy on suicide prevention, and at the moment a focus on young men. We have all our drug and alcohol services for prevention and treatment. We have all our mental health services. We have a focus on domestic abuse, obviously all our safeguarding work. And then if I go further than that, all our work on physical health, housing, the economy, benefits, etc., etc. So that doesn't mean to be a complaint about this process. I have actually asked that we try to define locally what we think we mean when we say public mental health, because to me it's so far from obvious that we all mean the same thing. But that's the sort of just a starting position for you to consider.
Bruce, thank you very much indeed. That's a great way to kick us off. And if I may, Bruce, so firstly, would you be able to say which area you're from, if that's okay? And then second, we completely recognise about the breadth of the topic. Do you have a shared definition in your area about what you term as well? Okay,
so I'm from Bath and North East Somerset, which is, I guess, a reasonably good area in many indicators, and but variable, like everywhere. And do we have? No, we don't. And that's one thing we're trying to work towards. I've asked someone in my team to literally do that, to say, well, if we're going to have this discussion, what's the circle we put around public mental health? But I myself am a bit resistant to the concept, because I think it becomes sort of it divides the physical and the mental, and I just don't particularly support that approach, because it can easily sort of pigeonhole mental health, and I think that pigeonholing to some extent is why it's not in the best place. So not yet is the answer to your direct question.
Bruce, thank you. Just so one quick reminder to colleagues, if you want to contribute, you can either put questions in on the text or raise your hand, and we'll bring you in. There's a couple of questions coming to just a second. But Luke, do you want to sort of come back on the point around that trade-off between putting a circle around mental health, as Bruce very nicely described it, versus actually that being quite divisive?
Yes, that, and I'd also just like to reflect, Bruce, thank you so much for your contributions and the long list that you provided, because I think what that says to us is, you really understand this agenda, you understand and get, and that's not our experience always in speaking to people about public mental health, that it touches all of those areas, and it's fundamental to have things in all of those areas. So I think the challenge for us is if we can try and find a way to provide some steer and guidance as to what we mean by having effective prevention planning and arrangements, and that means that it does need to span this breadth. I know that people who are working on this agenda can be very, very well informed on that, but we've still got a long way to go in kind of public understanding. So that was really, really helpful. Thank you. On the question of the division between physical and mental health, absolutely, we hear you. And there is that challenge, because if you separate mental health out, you're creating a false separation between physical and mental health. At the same time, if you keep it in a holistic way, you can suffer from a lack of focus on mental health within the physical health agenda. And so we are very alive to that tension and agree that the drawing of that circle is a challenge. And we accept that challenge as part of this work, and we're trying to provide, I suppose, a definition. We will, and there are lots of definitions of public mental health, many of which are debated, but we're trying to provide in this guidance some sort of steer as to what you would expect to find in a public mental health agenda, and that does not mean that it needs to be separate from your physical health agenda, but it just there needs to be an emphasis on the mental health aspects of that health agenda. I mean, that's my position where I'm coming from. I don't know if Lily wants to add a further comment.
Not much more to add than what Maeve has just said, but I think that, having worked in a few local authorities myself, I absolutely get where you're coming from in terms of understanding, and actually I think I wonder whether or not, and this is part of our exercise of engagement as well, is finding that level of where everybody is at as well. So what is the current norm? Where are the areas that are doing better and get it and we can learn from, and where are the areas where we want to actually raise the bar, and what is the bar that we want to set here? So so your conclusions were really useful in kind of adding, actually confirming some things that we'd already been thinking, actually, as well as kind of taking it a little bit further on.
Thank you, Lily. Thank you very much. We'd really welcome other colleagues' views on these issues. Just while people are thinking about that, just to bring in a couple of comments by text, which link into this really well. Kate Tahara, thank you very much again for comments talking about worry that if we do call it prevention, it feeds into the push in local authorities, public sector being to focus on the most vulnerable, and we need to move further down rather than upstream. So there's a range of issues just around the definition. We've also received a question in from Duncan Cooper, who's a public health consultant from Wakefield, who wasn't able to make today, but has emailed in to say, are we envisaging a crisis care Concordat approach eventually, which was quite specific, or more locally determined priorities? This goes very much to that the question we posed around process and priorities versus a broader approach. Lily or Maeve, would you like to comment on that, and then we'll bring in some more comments from text.
So what we've said from the beginning, so our and this may not, other people may have different reflections on this, but the crisis care Concordat approach was very much sort of set at a national agency level, and then my perception was then filtered down to local areas. And what we're trying to do is provide support to local areas and take a local first approach. So in terms of can this be locally determined, what we're trying to strike really in the guidance is a balance between a sort of structure of what we think should be part of effective prevention planning arrangements and support as to how to go about getting those in place, but specificity about what needs to happen will be locally determined. There are differences for sure in between the crisis care Concordat approach and the approach that we're taking on this prevention programme. Does that answer the question, do you think?
Yes, thank you very much. And Geraldine Strategy, thank you for joining us for the call. Again, just a comment asking for colleagues' views on how we get this balance in prevention strategies between what should be universal and what should be targeted. And I think it's fair to say, just in terms of where we are with the engagement, that this is a question which is open to us.
Yeah, alive.
And so, as you might have seen from the slide which we put forward, this is one of our earliest engagement events, and so this sort of discussion is incredibly helpful and useful. Questions coming through on the text, we'll get to those in a second. Just to say, if you do want to join verbally, do put up your hand. It should be the little icon, which to some people looks like a hand. To me, it looks like an upside-down hairdryer, and we will unmute you and and bring you in. Another question from Geraldine Ray. So what secondary prevention interventions are colleagues planning as part of their prevention Concordat, or do they see that as different? So a question about it. So let's clarify by to begin with. Is the prevention Concordat just about primary, secondary, or tertiary prevention, or do we span all three?
So we've said at the beginning of this presentation that where we start from is that it's spanning all three, particularly to give that opportunity for locally for that to be determined, because local areas and particularly different parts of the system will have a focus on different parts. So that's the first part. But on the specific question about what secondary prevention interventions are colleagues planning, I would really invite and welcome colleagues on the phone to share what they're doing locally. That would be brilliant to hear.
And so very much welcome people to come in on that. And Paul, thank you for your comment for just a second. And I think the point just to reinforce made that this work builds on the excellent document produced by the Mental Health Foundation earlier in the summer, which and it is a wonderful catalogue of the range of different interventions out there across primary, secondary and tertiary. And just the breadth of the field again was why we are particularly interested in processes colleagues have used locally in order to try and determine which areas to prioritise. Paul Lang, thank you very much for your comment on the text, which I'm going to read out, if that's okay. Paul, you were saying that you were recently asked to brief the Health and Wellbeing Board on what locally Public Health Invest in the Public Health Mental Health team. Some of the interventions we've delivered locally include mental health first aid, social prescribing, suicide audit, making every adult matter, and emotional wellbeing champions. What I couldn't quantify was the wider support within other commission services, such as health visitors, sexual health promotion, and these services have priority groups, including mental health. Paul, I think that's a really helpful intervention, as one of the issues we've been thinking through is we do not want public mental health to be seen as the preserve of health and care services, and how do we bring in those wider elements. Lily, I don't know if you want to comment on that, but we very much welcome colleagues' views on how they've managed to do that in their local area.
Well, I think what Paul's kind of hit upon there is one of the greatest challenges, in that this work is broad and it cuts across responsibilities in local setups. So how do you have that challenge of, I mean, is it through having a kind of community-wide articulated public mental health strategy, which draws together the elements of both the specific contributions of the public health team alongside all the contributions of other elements sitting in the local area, and does that help to articulate the fact that so many activities happening at a local level, from employment, from health visiting, from other work that's going on in schools, will all have an impact on the mental health of your population. Lily, did you want to chime in on that?
Yeah, I mean, again, just that it's the local. I think I would say that we need also, and again, which sounds like what you're doing, is that focusing on what your local area wants and needs. And so, again, one of the things we want to try and build into this is how do we get that the local intelligence, which would come from some of the tools we're providing, like the joint JSNA toolkit that we're providing, but also, you know, again, encouraging people to also listen to what local people are saying as well about what will work best, or trends that they've seen that need action on.
And on that point, Lily, a really good comment coming through from Tim Rice. Thank you, Tim. Saying, only a minor point, but please ensure documents talk to all local government, i.e. districts in two-tier areas, so they have the permission to support through their services and not just rely upon the upper tier.
Yeah, absolutely. That's that's one of our areas that's a must do.
But it is a challenge, because what we've been asked to do is to speak to local authorities, health and wellbeing boards, clinical commissioning groups, but that's also in an environment where there now is sustainability and transformation plans. So we are very alive to the challenge involved in doing that. But absolutely, we want to be speaking to all local government at all levels.
I think just reflecting on that, Maeve, and who do you see as the primary audience of the range of resources we're putting together?
I think it's just what I said. You know, health and wellbeing boards, local authorities, and clinical commissioning groups.
Thanks, Maeve. And it's this breadth of the audience. And Paul Lang, thank you to put in a comment about the process in terms of determining priorities, where you said it's generally set by the Health and Wellbeing Board. However, you're sort of looking to develop more of a prioritised process given the changes in funding. We'd be really interested in colleagues' views on the line whether it has been the Health and Wellbeing Board which has been playing a central role in determining public mental health strategies, or whether it's been led from other quarters. I think it's fair to say we've been working on the assumption of health and wellbeing boards having a really key role here.
We have, and I would be really interested also to hear from colleagues working in CCGs how this agenda comes across to you, because being led by Public Health England, we naturally work with our colleagues in local authorities all the time, and we do work, of course, through our connections with NHSE with our CCG colleagues, but it's not necessarily the primary audience for Public Health England. So it'd be really valuable to hear from those who are on the line or contributing questions who are particularly in a CCG context as to how this agenda is coming across to you.
May, thank you. I think we do have a few colleagues on the line from CCGs. So CCG colleagues, now is your time. If you'd like to come in, that would be excellent. Again, if you just want to, if you raise your hand by pressing the button, then we can unmute you and bring you in. I'll let that question sit. So
yes,
we really appreciate.
And I know we've had some email comments from CCG colleagues already, so we really appreciate those.
We've also had one other comment coming in through the email, a question from Mark Wheatley, who said, in terms of the mental health champions, how can they access training in this area? Has this been decided yet? Is there still time to get involved?
Yes, Lily will lead on the answer to that.
So we've already started to think through that. And our first step is going to be running alongside this development process. We're sort of testing out some training with the mental health champions, of which we're aiming to kind of get between 20 and 40 to go through a pilot scheme where we kind of upskill their skills and knowledge around prevention, particularly focused on mental health. But obviously there will be a sort of spin-off that actually enables their understanding of prevention more generally. And by that I mean, everything about that upstream element of improving the public's mental health. So it's not necessarily simply illness focused. It does capture that thing about mental health promotion. So we're running that so that those sort of training sessions will be happening in January and February of next year. So they'll precede the launch of the guidance, and then we'll look at whether or not we do more in the future, because we'll see we really do want to, again, having worked with elected members myself, I'm very keen that the importance is for them in the decision process, and actually how their views, not just on this issue, but on others that will help improve the public's mental health, will be quite a key thing for us to achieve. So it can be quite groundbreaking, really.
Lily, thank you very much. So it's worth saying, if there are any colleagues on the line who are part of the Mental Health Champions Network or have colleagues who are part of that network, we have a specific session for the Mental Health Champions Network next week. Again, do just email us if you'd like details of that. And we've had a number of comments now come through on the text. What I'm going to do is read a few out, which will be a variety of different questions, and then Lily and Maeve, I'll leave you to look at each other and work out which ones you want to take. So firstly, going back, Kate Harvey, you made a lovely point actually when we were talking about definitions, saying that the importance of defining is not necessarily just the definition, but the engagement in conversations to come to that shared understanding. There's lots of nods going on here. Geraldine, you asked how this work will align with the prevention elements of the crisis Concordat. So let's come back to that in just 1 second, Lily and Maeve. Geraldine, another question from you. Thank you, saying it'd be very useful to know what metrics people use to feel they've been successful. Do they have particular metrics which they use locally or a national source they relate to? So welcome colleagues' views on that, but I think we'll also just give a quick view here. Kate O'Hara, thank you for your question. How will you engage with the Combined Authority Mental Health Commission of the West Midlands? Planning and priority setting is very complex, STPs, health and wellbeing boards, etc. I think that's very true. Nirundeep, thank you very much in responding to the CCGs question. Nirundeep, just going to read out your text point, which was North West London CCGs have a mental health, predominantly mental illness strategy, and as part of that are looking at the targeted parenting programs through schools for children with early behavioural problems. This was prioritised due to the NAT literature review on ROIs. Excellent, good, really pleased to see that. It's part of the STP, so opportunities and an audience here. No, that is exactly what we're after. Thank you very much indeed. And then finally, Bruce, just a quick comment from you. I will share these in a second. Talking about prioritisation, saying there isn't one simple process. There are a lot of concurrent ones, including health and wellbeing board strategies, thematic strategies, centrally and politically driven priorities, opportunistic approaches based on resources, health and wellbeing boards and modest influence, local strategies selective, in our case, highlighting loneliness in early years rather than the sum of all other strategies. Certainly that coming together of lots of different strategies on a similar area is something which we're well aware of, and thank you for highlighting that again. So Lillian made a range of questions there. Should we start with the alignment with the prevention element of the crisis care Concordat? Is this work being designed? We all presume this work isn't being designed to duplicate other work which is
No, to complement. The specific question, I mean, I suppose one of the challenges for us there, Geraldine, is that local areas, as I understand it, sort of can define the prevention elements of the crisis care Concordat as they would like. So there's the general responsibilities you need to sign up to be part of the crisis care Concordat, but then the prevention agenda goes beyond that, and so I think this is one of our challenges in that in designing a resource, we need to make sure, and we have a similar challenge in terms of suicide prevention work, where there's already an enormous agenda and an enormous array of activity locally and nationally. So our strategy has been to say, of course, suicide prevention is a key part of any prevention agenda, but we're not going to duplicate all of the resources. We're going to signpost and signal to those existing resources, and we are going to trust that, of course, local areas will include suicide prevention in their planning, but we're not going to duplicate that advice. So I think a similar thing will happen with the crisis care Concordat work, which is, and that's what I meant at the beginning about, we're not being prescriptive about developing a joint prevention plan. We want to have effective prevention planning arrangements in place. So if in a local area, and this is I think sort of has to be pragmatic because every local area does things differently. If in a local area you want to cover a large amount of the prevention agenda through your crisis care Concordat agreements, that's okay. The most important thing is that you've thought it through and that you've covered those elements in the work. So I hope that goes some way to speaking of that answer. And I mean, Lily, I think a similar thing is probably in terms of how we will be engaging with the combined authority in the West Midlands, in that there is different arrangements across the country. So we're alive to that.
Yeah. So that everyone's in the similar place actually is that we, Kathleen, have actually been quite actively involved in the work that's been going on with the West Midlands Commission, and so I've been quite excited. Well, not just me, the whole team's been quite excited on how that's developed and why it's developed and some of the opportunities. So opportunistically, we have taken the opportunity to start to seed out, as we've gone along the way, test out and seed out some of the ideas that might be useful more generally for sort of prevention and promotion, but without it being under the umbrella of a prevention Concordat. and also not as far as it being a sort of trailblazer either, but it's just kind of helped us get a sense of the ground. And also, as you say, appreciating the complexity. We have a similar issue around Greater Manchester, although it's similar and yet different, as you'd appreciate, in terms of that whole sort of joint collective devolution efforts. And so what we are going to be doing again is that as we progress in terms of the, developing the guidance in terms of with the engagement events, the conversations we'll be having as a result of those, and the sort of testing after we've got the sample guidance, will be making sure that this does read and land well if you are in one of those sort of situations, again, where, as you know, you've got sort of multiple organisations, multiple different boundaries that are not necessarily the same as they were before, and various other sorts of things, and both governmentally and also across the NHS. So we acknowledge that challenge, and we're sort of accepting we need to sort of take that on.
Lily, thank you very much. We've got a range of questions coming thick and fast. Just the one point I think we didn't catch up on within that was just around metrics.
Oh, right.
Yeah.
Well, we've cracked this, haven't we? This is easy. No, it's not. Who'd like to come in?
Well, I think again, it's like, we're going to say this several times in this conversation, is that, and this is one of the things that we're drawing out of not just of these conversations, but also of looking at what else has been done, particularly in local areas, what sort of metrics have been used. And there are some strong clues coming forward, which is about that combination of things that are clearly labelled mental health, but some of the things might be other things about sort of general improvements. So that's a work in progress, and so the ways we're doing that, as well as these conversations, is, as Maeve said earlier, is that we're kind of putting together what are the examples. It's quite a structured way of putting together the examples of the good and effective approaches, and what local areas have chosen to do. We then also do need to identify what the overall national ambition is, but again, we're sort of closing in on that as we move forward.
Yeah, I think that's an important sort of point to come back on. There was an opportunity at the beginning of this process, and some stakeholders suggested this, that we should choose a specific national target, for example, levels of common mental health disorders, and set a target for 5 years' time for a national reduction. And we have very much moved away from that approach, because the breadth of this agenda, that, as we've all discussed, is so broad. Choosing a single metric to focus a national ambition on, we felt was just going to not cover the agenda. There's obviously a trade-off with that, and it would be interesting to hear colleagues' views in that if you have a national ambition and a single figure, it may well galvanise action in that area. But we decided that more variation was the right way to go. So that's where we've come out.
Maeve, thank you very much. We've had a couple more questions come through from email, which we'll do email and then go back onto the web questions. So a comment from Mark Wheatley. Mark, thank you for joining us, saying we have a similar approach to that which Bruce discussed earlier, prioritising mental wellbeing in schools, the workplace, something about older people, suicide prevention, also links to time to change, the pledge. We have a needs assessment on mental health in Leicester. This provides intelligence to underpin a public mental health approach. I think that public mental health is probably a useful label, but it informs promotion of well-being, preventing disorder, and identifying and treating mental health problems as early as possible. Really useful comments, Mark. Thank you very much. And also from another comment from Duncan Cooper. Thank you for joining, Duncan, saying great developments are in children's mental health, working with CCG around future in mind, but this was well funded. So do we need a similar central funding stream for working age adults, workplace mental health, social isolation, etc.? Both the navigator roles and early intervention, so we might want just to touch on funding, Lily and Maeve. And there's so many potential interventions that the prioritisation has to be done via evidence-based, but also local mapping of good relationships and joint working, such as governance structures, as this will actually determine success. Duncan, I think that's a fantastic point just there. I'm just going to take a couple more comments from the questions, and just say if people do want to raise their hand and we can hear voices, then you're very welcome. Or we can continue by text. So Jeanette Searle, thank you, put a really nice comment in talking about prioritisation, saying Reading's new health and wellbeing strategy is out of consultation at the moment. Good mental health and emotional wellbeing for children and young people is likely to emerge as a priority, as is reducing loneliness, which of course links to emotional and physical wellbeing. Both of these seem to have a lot of resonance with the public. So schools again coming through there. And then final comment, and then Lily, maybe I'll turn to you. Bruce Lawrence saying, just a quick point, are we including dementia and its prevention in this whole discussion? So direct questions there around dementia. Be good to touch on funding, and also to talk about this approach in Reading seeming to focus on issues which resonate with the children, with the public being a constructive way forward. Lily and May.
So on dementia, we are not explicitly covering within this programme everything that needs to happen on dementia, but we know that some local areas would choose to do mental health and dementia together. So that's part of the kind of local tailoring of this approach. If that's how it works locally and you want to do effective prevention planning across mental health and dementia, that's fine from our point of view, but the guidance is going to specifically support the mental health elements of the prevention planning. So I hope that's clear. So I mean, an example of a strategy that we reflect on frequently is Warwickshire, and in Warwickshire, in their public mental health strategy, they do include dementia. So that's part of the local tailoring. Central funding, of course, we would love more central funding, but we are all aware that that's not the current state of play, and we know that this recommendation from the task force does not come with funding attached to it. So that is one of our biggest challenges, is that the environment that we're trying to get this prioritised is in an environment where funding is being cut. So that is one of the greatest challenges. And then the question that Jeanette, or the reflection Jeanette gave about issues that resonate with the public. So that's one of the things we're really struggling with in the structuring of the guidance, and it would be really useful to come back to Bruce as well, who talked about the processes which you explained, Bruce, the number of processes that happen locally in order to get to your prioritisation, through to health and wellbeing strategic views, through to opportunistic things that pop up. And I suppose my question back is, well, what would be most helpful for you in guidance? How could the guidance help? And one of the trade-offs we're thinking, well, lots of the trade-offs we're thinking there is, do you go specific on a set number of, on specific interventions that really should be looked at? Do you go specific on specific populations that need to be included? Or do you set out a process, and that process might involve public engagement and specific if the public of your area want to focus on loneliness and children, and that's where you get political buy-in from your councillors, is that okay? So welcome reflections.
So Bruce, you raised your hand, and you may be raising your hand to raise a completely different point, but we've hijacked it now to talk, hopefully, to get your views on those prioritisation issues. Bruce, we hope that you are muted, you can hear us, we can hear you. Over to you.
I actually raised my hand to make the point, then I put in a little comment on the site about not about the metrics and indicators should reflect the way we have metrics and indicators for community health. So some of the wide determinants, the very upstream determinants that underpin mental health, like employment, poverty, and then some of the more proximal determinants around numbers of people misusing alcohol, amounts of domestic violence, and then some of the outcomes. So I think what you do is you demonstrate in the way you work with metrics, you demonstrate the width and the upstream to outcome elements of public mental health. That was just a thought. In terms of your comments about what the question you just asked about what we should be, how you should be dealing with this, yes, it's not an easy question, but I think what will come out of this, if anything useful does, is to raise awareness of the the wide impact that you can have, the wide determinants of public mental health in the different strategies that we might have for many things, and is that being addressed through the width of our thinking and the width of our strategies? So some of those areas of good practice would be helpful. Defining the scope of it would be helpful. I think processes maybe. I think every area will have its own ways of doing business and processes, and if you try and sort of force it too much down a route, it might not be helpful. But perhaps some kind of at least checklist would be useful to make sure people are putting their thinking in the right direction, not exhaustive, but at least some kind of checklist might be helpful. That's just a bit thinking off the top of my head.
Thank you, Bruce.
Bruce, thank you. That's a really nice sort of comment, and certainly a checklist is something which I think we could reflect on a bit further. A comment from Kate Harver. Thank you, Kate, saying useful for the guidance to cover sort of all three areas: interventions, population, and process. We'll try and keep this guidance shorter than the Encyclopedia Britannica, but it's we'll want this to be the most helpful document possible. Yeah, can I just say we've got 7 minutes remaining, so it'll be good to keep a bit of the discussion going for a couple more minutes, then we'll talk about next steps. But if I could give people one bit of homework just to be thinking about, we'd be really interested after this call finishes, if you could just email us, and the email address is in the slides, what is the single piece of advice you would give us to make this work most likely to succeed? So if you want to email us afterwards or to put it in the chat, either is fine. But if everyone on the call could just be thinking, what's the single piece of advice that they would give us to help this work succeed? So we've got a couple of minutes left. If there are any final reflections or comments just on the questions which we put up there, or any of the discussion we've had today before we turn to next steps. Lily, May, sort of any we're coming to closing reflections. We'd like to summarise 54 minutes of excellent discussion in about 30 seconds.
Well, I'd first of all just like to really thank everybody for all their contributions. Some of them, they've been coming thick and fast, so we'll also reflect on your comments in more depth after this call, so we really, really appreciate that. I think for me, it's interesting, many of the questions that you've posed back to us are the ones we're grappling with, so that reassures us that we're grappling in the right areas. This is a very broad agenda. We want to have impact, but the complexity of doing that, both because the agenda is wide-ranging, but also the circumstances that people are working in locally are so different, is really top of mind for us. And we're also, I'm interested, I'll need to check through the comments again, but it was really helpful to have Nirandeep's comments from the CCG in North West London that, you know, the focus strategically there is still a sort of mental illness strategy. So the promotion prevention agenda is our sense is that that's going to be more new for CCG colleagues, and so that's something we're going to be, you know, finally balancing in the resource.
Maeve, that is an admirable job to reflect such a lot of conversations so quickly. Thank you very much indeed for that. We're now just going to quickly talk about next steps. In just a couple of minutes left, we've got just again to reiterate, if people are able to share with us what is the one piece of advice, the single piece of advice they would give us in order to make this work most likely to succeed, please do put it on the text or email us. What are the next steps, Maeve? Where do we go after this in the last couple of minutes?
Well, as we said, we'd obviously be delighted if people wanted or were able to join us for our face-to-face engagement events. We also we'd continue to like to hear your comments, and we've given Tanuja's email address as a way to get into contact with us on those comments. In terms of the kind of next steps, we're going to be, between now and December, listening, very much in listening mode as we go around the country, and then in synthesis mode as we try to, in early December, put this together into what we think a kind of draft looks like for this guidance, and that will be informed. We will have more insights from the King's Fund research as well alongside that. And then the new year is really our opportunity to test what's come out with stakeholders. And we have planned to have a webinar in January to play back the themes and the shape of the guidance. Probably won't be a draft format, but all of you would be very welcome to join that webinar, and details will come out probably in December for that webinar in January. I should have said, and I apologise that I didn't, but we have a steering group overseeing this work, and we have our first meeting with them tomorrow, and we will be engaging with them today. Tomorrow is Saturday, today, this afternoon, and we'll be engaging with them in December again and in January, because obviously there's a quick pace in developing this work. So I think that the next opportunity is, please keep in touch with us, and please join us for our update webinar in January when we've done our listening and some of our synthesis, and we'd like to play back to you the shape of the guidance before we move towards having a more finalised product for March.
Maeve, thank you very much. And just to say that January webinar, we're just still finalising the date, but we will share that with everyone who signed up for today as soon as possible. So we very much hope to see you at one of our regional events, if not back at a webinar, or get in contact with email, or just come and stand outside Skipton House and grab us as we walk by. We appreciate this is an incredibly challenging agenda, particularly in the current environment, and the only way we're going to be able to make progress on it is through building on the advice and expertise which is so apparent through this conversation today. So thank you once again for joining. Please do email through any sort of comments, and thank you for those who've sent through a couple of killer points already. That's really helpful, and hope that people can take this, reflect on it, and send us further views. We'd very much like to hear them. Without further ado, I think we'll say at 10:59 we will end this webinar. So thank you all very much indeed, and we hope to hear from you as this programme develops. Thank you.
Thank you.
Thank you.